Okay, so I figured I had a little more time before I go out for tonight, so I could come on and do the next topic in cardiovascular, which is the various types of arrhythmias and their management. Now, as always, a lot of these things are things that are going to be repeated from what you've already seen in step 1. So it was already there in first aid. There are a couple more breakdowns, right? So if we go back to just look at what was in first aid, they kind of summarized it all in just one page. Let's see. So actually it was right at the end of physio. Yeah, so this page right here, right? They had all their Ecg tracings, as they called it. They had the rhythm issues of atrial fibrillation, atrial flutter, and ventricular fibrillation. And then they had the AV block issues, right? First degree, second degree, type 1 and 2, and then third degree. And they showed you some fake ECG drawings that were supposed to depict what it'll look like on an ECG if a patient has any of these issues. So this is, just touching the top, really. There's a lot more than that. So there's about a good 4 or 5 pages right now where we're going to look at all the different kinds of ECG tracings you can find in various arrhythmias and how you're supposed to manage them. So over here, table 2.1-3 outlines the etiologies, clinical presentation, and the treatment of common Brady arrhythmias and conduction abnormalities. I made a note here. I wrote, visit the ACLS website to see algorithms for managing various conduction abnormalities. When I was on the ACLS website earlier, I saw that they had a breakdown for each one of the major issues. Someone coming with AFib, atrial flutter, ventricular tachycardia, ventricular fibrillation, whatever it might be. They have an entire management breakdown on their website. So they've done a really good job, and that's basically the protocol we all follow in American hospitals. All patients with persistent tachyarrhythmia causing hemodynamic instability should be managed with immediate synchronized direct current cardioversion. So cardioversion, everyone knows, of course, that's what you manage it with. There was a more detailed answer on UWorld, so they call it synchronized direct current cardioversion due to the risk of rapid clinical deterioration. All right, so any patient with persistent tachyarrhythmia that's having hemodynamic instability, you put them on that. Synchronized cardioversion involves the delivery of a low energy electric shock that is synchronized to their QRS complex. All right, so it's going to be making things a little better. Defibrillation, that's unsynchronized cardioversion, right? So unsynchronized cardioversion provides a high energy shock at a random point in the cardiac cycle and is used during resuscitation efforts in patients with pulseless cardiac arrest who have a shockable rhythm. So there was a question, I might have it in here later on, where both answer choices are there, synchronized direct current or unsynchronized, and then you have to pick which is the correct thing. So it really helps to know. The mnemonic on the top right over here, the ABCD, that's something that's very old from step 1 as well. It's something you just really need to know for atrial fibrillation, which is obviously one of the most high-yield things you'll possibly see. So anyone with AFib, you anticoagulate them, you put them on beta blockers to slow down their heart rate. You do cardioversion if necessary. You give them a calcium channel blocker to slow down the heart rate. Once again, AV Nodal, and digoxin to help their heart actually beat correctly, right? So digoxin is going to increase contractility in a sense. So here now, the first thing they have are all your Brady arrhythmias and conduction abnormalities. So Brady arrhythmias, everything with slower heart rate. And generally speaking, what you're going to start seeing is that the distance between R waves, the various QRS complexes, is just going to be a lot bigger. So you can see how normally we look for about 3 to 4 boxes, and then you should have another QRS complex right here. But this is spanning more than 4 boxes, right? More than 5 boxes for this one. So that is very slow, right? Very slow heart rate. So this first one here is Sinus Bradycardia. Normal response to cardiovascular conditioning can also result from sinus node function or dysfunction, beta blockers, or calcium channel blocker excess. Someone trying to overdose on either beta blockers or calcium channel blockers. Therefore, it's important to review all medications. And this is pretty much true for anyone, almost for any pathology any patient comes in for. You want to make sure you review all their medications, that they're taking it correctly, and if there were any medications they recently just randomly stopped, right? So one of the most important ones you never want your patient to randomly stop is something like prednisone. If you've been taking prednisone for like 3-4 weeks, and then maybe 2 months into it they started gaining weight and they were like, I'm not going to take this anymore, that's terrible for them because that's going to lead to Cushing issues, right? You're supposed to wean it off, can't just randomly stop taking it. may be asymptomatic, but may also present with lightheadedness, syncope, chest pain, or hypotension. Sinus rhythm is going to be there because if the sinus node is working, and the ventricular rate is going to be under 60. So remember, a good normal heart rate is about 70 to 100, right? And if you have a patient who has a heart rate of almost 60, you don't want to give them beta blockers because then at that point you risk bringing it even lower than 60. So this is one of the case scenarios where no real treatment is often necessary, right? So they wrote right here, treatment none if asymptomatic and the heart rate is more than 40, right? You can give atropine to increase heart rate if necessary. Pacemaker implant is the definitive treatment in severe cases where the heart rate might be less than 40, at which point the patient has a risk of dying, and of course they'll have extreme trouble being able to do anything like extreme activities of any sort. Now, when I was going through all of this, I put together the various arrhythmias and stuff based off of the treatment necessary. So you can see how, in the book it's listed as, they just list out all the different diseases and then they tell you the treatment for each one. I relisted them in order of what treatment you use for each thing, right? So the no treatment things were sinus bradycardia, someone with first degree AV block, and then if you have second degree type 1, right? Those are things that don't necessarily require treatment unless it's getting really bad, if they're becoming very, very symptomatic. Right? Then there's things that require pacemakers, such as a second degree AV type 2, third degree AV block, and someone with 6 sinus syndrome, so we'll look into what that is. You do the ABCD stuff for anyone with atrial fibrillation, atrial flutter, or multifocal atrial tachycardia. Cardioversion is going to be necessary for AV nodal RT and AV RT. We're going to see those pretty soon too. You need to observe or give procainamide/amiodarone for people who have Wolff-Parkinson-White syndrome, depending on how symptomatic they are, okay? And you have to make sure you don't give them calcium channel blockers at all, or really digoxin, but definitely not calcium channel blockers because you don't want to worsen their AV nodal capabilities. Radiofrequency ablation is the actual full-blown treatment for Wolff-Parkinson-White syndrome if it's really symptomatic and they need help. Adenosine can be used for AV-NRT, and it can be used for paroxysmal atrial tachycardia. Beta blockers and antiarrhythmics are for PVC. Cardioversion of class 1. Okay, so class 1/3 antiarrhythmics. What I'm writing here is you can use cardioversion, or you can use class 1 or class 3 antiarrhythmics for ventricular tachycardia, but not class 2 or 4. And then defibrillation. So that was the unsynchronized cardioversion for ventricular fibrillation. And of course, anyone with torsades, you give them not magnesium, but magnesium, and do cardioversion as necessary. So this was a great way to list it out because you're going to get questions and then they're going to ask you what the best next step in management is, and they might even ask you what to do to treat it. What would be the most necessary or appropriate step to take for treatment purposes. So at that point, it's only going to get a little more confusing if you don't have it down solidly which thing you do for each one of these. So we just talked about sinus bradycardia. Now we're looking at first degree AV block, which was there in first aid step 1 as well, right? First degree AV block, the PR interval is prolonged for more than 200 milliseconds. Normally it's supposed to be 200. This is pretty benign and asymptomatic, and no real treatment is necessary. So you can see the distance between QRS complexes is still pretty even. The PR is just a little longer than it was supposed to be, but patients will be just fine. And it's very unlikely that a patient is going to present with significant symptoms or any symptoms for the most part. So they tell you that it can occur in normal individuals associated with increased vagal tone, which is parasympathetic, so it's more resting, beta blocker or calcium channel blocker use. PR interval more than 200, none necessary, right? No treatment is necessary. And you can pretty much, just note that the distance between these guys is going to be increased simply because you lengthened the PR distance, all right? But other than that, nothing crazy about this one. Second degree, there's type 1 and type 2. So when we did it in first aid step 1, we talked about how to memorize the difference between type 1 and type 2. Mobitz type 1 is the Wenckebach one, and that's progressive lengthening of the PR interval until a beat is dropped. A P wave not followed by a QRS complex, usually asymptomatic. Variable RR interval with the pattern regularly irregular. Right? And they're going to tell you that in question. They'll tell you that the pulse of the patient is regularly irregular. And they show you that in this fake ECG here, so you can see how this QRS complex is missing right there. So what you do is you think of type 1 as type 1 has one dropped QRS as the PR lengthens. You can also think of it as finding the one you love, falling more and more in love with them, and suddenly skipping a beat due to the affection, right? So these are just two different memorization things I had used when I was studying in the beginning, because I would often forget that type 1 has one drop. And that wasn't enough because type 2 also has absent QRS complexes, so you have to remember that the key thing in type 1 is the progressively falling more in love, or the progressive lengthening of the PR. Right? The PR keeps getting longer and longer until a QRS is dropped. In type 2, I wrote type 2 has two equivalent PR intervals that lead to a missing QRS complex. Right? So that's the big thing here. PR interval doesn't get longer. PR stays the same, it's equal, and then all of a sudden you're missing a QRS complex. Right? So that's the difference between type 1 and type 2 second degree AV block. And both of them, so first for this one, the AV block type 1, they tell you it could be due to drugs, it could be due to increased vagal tone, or it could be due to right coronary ischemia infarction, where you would see 2,3 AVF, ST depression, or ST elevation on ECG. Progressive PR lengthening until a dropped beat occurs, the PR interval then resets, and then it repeats again. None necessary, right? So again, as I said, just it really helps to list things out in terms of what treatment is necessary. So we have three things here already that did not really require anything unless it became symptomatic. If it became symptomatic, Sinus Bradycardia had a pacemaker, and second degree AV block, you also use a pacemaker. Right? But again, even if asymptomatic for the second degree one, that one is, even if they're asymptomatic, you have to give them a pacemaker because this can get really bad. So what's so bad over here? This results from fibrotic disease of the conduction system, or from acute, subacute, or prior MI. Right, so if someone had a prior MI, then they recovered with fibrosis, and then things can get worse. So they really need to get a pacemaker placed because these people can have sudden cardiac death. Occasionally, they might notice some syncope. Frequent progression to third degree AV block is possible. And to stop all of that from happening, just put a pacemaker in them and they will be fine. Okay. Third degree AV block is really bad, so there's no communication between the atria and the ventricles, and of course they do need to communicate with each other so that they can beat in good rhythm, right? The atria contracts, then the ventricle contracts. If they both contract at the same time, it's kind of pointless there, and the wrong valves will start opening. So third degree AV block, it's a common sequel of Lyme disease as well. You have to remember that. They didn't put that in CK. Maybe it's in another section of CK. But here they wrote it, right? Can be caused by Lyme disease, and that's the one we learned in microbiology. So Borrelia burgdorferi, you got to make sure that you can make that connection when you see it. No relationship between P waves and QRS complexes, and oftentimes you might even see P waves and QRS complexes on top of each other, like they showed here. Right, so there's a P wave on the QRS complex. Here there's a P wave on the T wave. Right, so it's all really funky looking, and there's a lot of QRS complexes that are clearly missing. Right, so you have very long RRs and a whole bunch of Ps because it's easier for atria to keep contracting and it's harder for ventricles to contract. So you might have 3 atrial contractions, then 1 ventricular contraction, and that's all wacky and out of connection. So there's something you have to remember here that people often tend to overlook is the Canon A waves. Right, so just keep that in mind. This could be an answer choice that you might see here, and you can Google it to find more images showing you Canon A waves, but it's just something related to third degree AV blocks. And again, just give them a pacemaker. Right, so generally speaking, for any AV block, you only really care about the worst ones, which are the type 2 and third degree. Right, second degree, type 2, and third degree. And how do you treat both of them? You just give them a pacemaker, because the only issue here is the pace, the order in which things are beating and how they're beating. So just fix it with a pacemaker and the patient will be fine. Other than that, the others were perfectly fine, nothing crazy about them. Last thing on this page is sick sinus syndrome, also tachycardia bradycardia syndrome. Both of these are pretty low yield, but CK would like to ask you questions about it, so you want to make sure you know it. Heterogeneous disorder that leads to intermittent supraventricular tachyarrhythmias and bradyarrhythmias. Secondary to tachycardia or bradycardia, atrial fibrillation and thromboembolism may occur, leading to syncope, palpitations, dyspnea, chest pain, transient ischemic attacks, and or stroke. So this is clearly pretty bad. Most common indication for pacemaker placement, anticoagulated atrial fibrillation or flutter to prevent systemic emboli. But again, generally speaking, the treatment for sinus syndrome is just to use a pacemaker, right? And anyone that has an atrial fibrillation or atrial flutter, you always do the ABCD stuff, which includes anticoagulating. So that goes without saying. Let's take a look at this image I put here. So this one right here is supposed to be showing you what's happening in sinus syndrome, right? So again, whenever you look at ECGs, you want to kind of evaluate everything in the same way. So we have our left and right stuff. You want to make sure you see the R wave progression on the right side. Actually, they broke it down in a weird way here. Oh, it is still left and right, but it's okay. So V1 to V6 is just going straight down here. Okay, instead of putting V1, V2, V3, and then V4, V5, V6, they put it all straight down. So if you look at V1 through V6, you can see somewhat of an R wave progression, so that's okay. Right? This is pointing down, which is normal, and then it's getting longer and longer until most of it just ends up at the top and no more pointing down. So that's your normal V wave progression there. If we look at 2, 3, and AVF, so 2, 3, and AVF, now we could kind of start seeing things that are looking a little weird. First thing, you can see that there's asymmetry in the distance. This distance is tiny, but from that R to this R is almost double the length. Right? And then this one is also pretty long, but not equally as long. So there's some kind of weird asymmetry in length happening there. On top of that, it's very unclear why these guys are so tiny. Like, look at how tiny this one is. It's not supposed to be that small of a QRS complex. Other than that, there's really nothing else, right? You can see some kind of elevation here. There's some weird stuff happening here that doesn't look so normal. But whatever's happening to this patient doesn't fit any of the previous things we've looked at up here. It's not a first, second, or third degree AV block, and it's not a sinus bradycardia either. So this is sick sinus syndrome. Tachycardia bradycardia syndrome is a variant of sick sinus syndrome in which the arrhythmia alternates between slow and fast heart rates. And that's exactly what we kind of see in our ECG here. Right? So here it's a fast heart rate, then you have the slow heart rate. This is still slow, and then it'll probably get fast again. And that's kind of what we're seeing here. Normally speaking, this is not going to occur in any other ECG where the patient is doing okay. Right? So that's a big giveaway when you see that. When you see a small distance, then you see a big distance, and then it stays big. And if we had more of it, it would probably be another one where it's small again, and then again big. Right? And that's the tracing you would get if we had full length, longer tracings to look at. Usually related to ischemic heart disease or valvular heart disease, might note Stokes-Adams attack, which is a fainting due to asystole or ventricular fibrillation. You can also note angina or nausea, common in the elderly after scar-like degeneration of their heart. All right, so very important to watch out for this. This is usually, CK and UWorld and Amboss, they like asking this question because it's not so standard as the other things that we've looked at so far. So these were some of your Brady arrhythmias, right? Brady arrhythmias and conduction abnormalities, and since they're just conduction abnormalities for the most part, treatment just involved using a pacemaker. The next few, these are now going to be tachyarrhythmias. So before we delve into them, let's take a look at this question here. This was a really interesting question that a lot of people messed up. Only 40% were able to get this right. So UWorld question that says, a 42-year-old man comes to the physician for recurrent palpitations. After initial evaluation, he is diagnosed with paroxysmal atrial fibrillation. Echo shows normal left ventricular function and no valvular disease. He is initiated on medication. 2 weeks later, he undergoes a treadmill exercise stress test. During the test, his heart rate increases from 75 to 165, and the QRS complex duration increases from 0.09 to 0.13. What medication is most likely responsible for these findings? And this was really random because you don't really think of medications that could do something like this, but the answer here was actually flecainide. So flecainide is a class 1C antiarrhythmic sodium blocker. In patients with faster heart rates, the drug has less time to dissociate from sodium channels, leading to a higher number of blocked channels. This progressive decrease in conduction causes wide QRS, and this phenomenon is termed use dependence. So I never knew about this kind of thinking, right? I did not know that people who have faster heart rates would have a lesser amount of time for the drug to dissociate, and if the drug does not dissociate, then you're going to have more sodium channel blockade. So generally speaking, what this is saying is that an increased heart rate amplifies the drug's effect. Okay, and this guy, when he did his running thing, when he ran on the treadmill, his heart rate went up a lot, but then his QRS complex duration also increased, and that's not normal. Right, so now his QRS was taking longer to finish. The QRS complex was going from Q to S in a very longer time. Well, not very longer time, but longer than normal. Right, it increased by 0.04. But apparently 0.04 was significant enough. So if you forgot some of your cardiovascular farm drugs, then you want to make sure you go back and look at all of them again before you even continue doing more cardiovascular here. As you can see here with the class 1 medications, they kind of all have an effect on the sodium channel, and the sodium channel is more so related to this, right, the phase 0 slope. And what we're looking at is flecainide. So flecainide is a class 1C sodium channel blocker, which really significantly tilts over phase 0, right? And class 1C, the C you have to remember is for contraindicated. It is contraindicated in structural and ischemic heart disease because it will only make them really bad, right? Their heart is going to have a harder time working correctly. 1B is better post-MI because 1B is pretty weak, right? It's a weak sodium channel blocker. But 1C is a very strong sodium channel blocker, and increasing the heart rate actually makes this medication work even more effectively, which is going to suck for them because you don't want to prolong the QRS that much. QRS prolongation will eventually kind of have symptoms similar to torsades, so you don't want to have, not torsades, but increased QT interval, I guess sort of like torsades, yeah. Right, so increased QT interval kind of stuff. So you don't want to have that. You don't want to make patients go through something like that. But this question wasn't even very clinical. You know, this question is very much like really trying to just teach you something new. This is a very unrealistic question, but it was worthwhile just for the lesson it teaches, right? The concept of use dependence. So digoxin and verapamil, metoprolol, and amlodipine were all irrelevant, wrong answer choices. But overall, I think it's a pretty weird question, but it is what it is. Right, so these are your sodium channel blockers right here. You want to make sure you go back and review all your various antiarrhythmic medications before you finish the rest of this, because these are pretty high yield. They will show up, especially adenosine. You're going to be using a lot of that to terminate SVTs, ventricular tachycardias. You're also going to see Brady in here as well. So none of this goes away, right? None of this is gone. None of this is going to be less significant now. It's all equally as significant as it was before. Some things are even more significant. So now we have sinus tachycardia, an increased heart rate, right? So normal physiologic response to fear, pain, and exercise can also be secondary to hyperthyroidism, volume contraction, infection, or a pulmonary embolism. And you basically note a heart rate over 100. Which is the rapid early depolarization phase? Which question are you in this question? I didn't write anything about rapid early depolarization. So with sinus tachycardia, this is the only main thing here. It's not the worst thing, right? It's not a big problem, and this also doesn't directly require any kind of treatment. What you do need to do is treat whatever's causing it. Right? But it is a physiologic response, it's not really a pathologic response. It's a physiologic response to whatever's happening. So you treat what's causing it. Now, you don't need to treat exercise. That's good. This is supposed to occur in exercise. But if they have a panic disorder, then you need to treat the panic disorder. If they have anxiety issues, you need to treat their anxiety issues. And if, of course, they have hyperthyroidism, volume contraction, infection, or PE, those you definitely have to get rid of and fix, right? And when we get to endocrine, we're going to see a lot more of the hyperthyroidism and all those stuff. Atrial fibrillation, one of the most high-yield topics that always shows up on every test, right? Acute atrial fibrillation, they have this mnemonic of pirates, all the things that can cause acute AF. You have pulmonary disease, ischemia, rheumatic heart disease, anemia or an atrial myxoma, thyrotoxicosis, having ethanol, so drinking too much. There was also Monday disease. We're going to go back and look at that. And then sepsis. Okay, chronic atrial fibrillation can be due to hypertension or congestive heart failure, most often caused by ectopic foci within the pulmonary veins. Okay, and this is very important to remember. This always shows up in questions as well as in answer choices, so you want to make sure you remember that it has to do with the pulmonary veins. The pulmonary veins are going to be a big deal here, and those are the guys that are bringing blood back into the left atrium. So you have your 4 pulmonary veins here, right? And in this image, what you're seeing is they're using an ablation catheter to ablate the various places that this is occurring in near the pulmonary vein. Oh, that's probably from one of the step 1 things, so I'm not sure what that was, but yeah, that question wasn't for CK, so I didn't see which question you saw though. So continuing this, atrial fibrillation, these little tracings they give are very basic. Like for example, this tracing they gave here is very useless. It doesn't really do the job in my opinion. But with atrial fibrillation, going back to what they have over here, here. So atrial fibrillation, this is what it's really supposed to look like, right? So you really want to start seeing something like this where the QRS complexes are not equidistant from each other at all, and there's a bunch of random little humps, right? A lot of random P's and T's all over the place. Irregular baseline. There's no good normal baseline. Okay, so generally speaking, absent P waves. You can't really pick out which one is the P wave preceding any QRS complex. And that's your atrial fibrillation. Now, with the ethanol thing, there was this thing, not Monday disease, holiday heart syndrome, right? Holiday heart syndrome. Someone that went binge drinking, and then all of a sudden started noticing symptoms of atrial fibrillation. And there was a question. I think it's this one right here. No, not even that one really. Where did I used to have it somewhere. I don't know where it is, but there was a question where a patient had gone he was on vacation, he went partying, he drank a lot for the last 2 nights or something, and then the 3rd day he was feeling some weird symptoms in his heart, and that was holiday heart syndrome, right? So occasion seen after binge drinking. And you want to make sure you remember that ethanol can cause atrial fibrillation. And the treatment, they tell you anticoagulation, rate control, rhythm control, and/or cardioversion, which is basically based off of the ABCD stuff. Right, so pulmonary veins, definitely want to make sure you remember that. They go on to tell you often asymptomatic and incidental, but can present with shortness of breath, chest pain, dizziness, fatigue, or palpitations. Generally speaking, most patients will come presenting with chest pain and palpitations. May present with congestive heart failure, cardiogenic shock, or devastating cerebrovascular accident. Physical exam reveals an irregular pulse. There will not be any discernible P waves with variable and irregular QRS response. Right? And then they tell you how to treat each one. So for chronic atrial fibrillation, initial therapy is with rate control using beta blockers, calcium channel blockers, or digoxin. And then you have to anticoagulate them because when you have atrial fibrillation, way back in step 1, we saw in the beginning, I think I have it right here somewhere, there's something called an atrial appendage, right? So there's this pocket here in the left atrium that can stock blood into it, right? You can make a thrombus in there. And with atrial fibrillation, that thrombus can come out, go into your left ventricle, then go into the aorta, and then go into the brain and cause a stroke. That would really suck. So what you're seeing in this question here is the placement of a Watchman device in the left atrial appendage. Right? This Watchman device is really only there to make sure that no blood stockpiles in that appendage anymore. And that's something that can normally form. Any of us can have it, and there's really nothing you can do about it. Right? So anticoagulation is very important because you don't want something you don't want any thrombus to come out of the left heart and then go into circulation and go into the tiny vessels in the brain and cause a stroke. So anticoagulate with warfarin or any novel oral anticoagulant. That's the NOAC, novel oral anticoagulant. You're going to see this mnemonic many times in the rest of the book. For patients with any of this score, the CHAD score of more than 2. So now the CHAD score is something you use for congestive heart failure, and we're going to look more into it soon enough. But here I wrote the CHAD's VAC score is a clinical prediction rule for estimating the risk of stroke in patients with non-rheumatic atrial fibrillation. The max score is 9, and A75 plus can be 2 points. Okay, So we're gonna look at this pretty soon and see why it's 9 and not 10 points, and how you're supposed to use this in the clinical setting to figure out if someone is at risk of having a stroke. Here we're using it to see if someone with atrial fibrillation is at risk of having a stroke. Okay. For unstable atrial fibrillation or new onset acute atrial fibrillation, just do cardioversion and then they should be better. If more than 2 days or unclear duration, must get a tracheoesophageal echo to rule out atrial clot. Alright, this is something that's I've never really seen this in a question, doing a TEE to rule out atrial clot, but it's clearly a thing. So hopefully, if you see it, it'll ring a bell. Alright, but this is the ablation that you do. This is the ablation you do, and your ablation has to be near the pulmonary veins. So make sure you keep that in mind. I wrote that here. Use radiofrequency ablation to create lesions that electrically isolate the focal triggers of the atrial fibrillation, and those focal triggers are usually around the pulmonary veins in the left atrium. Next thing here is your atrial flutter, which has the shark-like thing, right? So now you see a bunch of P waves, or things that look like P waves, circular movement of electrical activity around the atrium at a rate of approximately 300 times per minute. Usually asymptomatic, but can present with palpitations, syncope, and lightheadedness. Regular rhythms, sawtooth appearance of P waves can be seen. This atrial rate is again very high, which is why this is under tachyarrhythmias. Right? So it's a very high heart rate, and the ventricular rate is about 150 beats per minute. Right? So the atria, as you can see, there's basically 3 atrial contractions for 1 ventricular contraction. That's kind of what's happening there. Right? It's not going to stay like that. You might have sometimes 2 atrial contractions to 1 ventricular contraction, or 4 atrial contractions to 1 ventricular contraction. And you can see they did a pretty decent job in their basic squiggle of an ECG to show you what's happening. Treat the same way as atrial fibrillation, right? Same guidelines as atrial fibrillation, nothing special, pretty easy to deal with. Patients should be pretty easy to take care of in that sense. A multifocal atrial tachycardia has multiple atrial pacemakers or reentrant pathways associated with COPD or hypoxemia, mainly just COPD. Alright, so if you have a COPD patient who's really not taking care of their COPD well at all, they're still not stopping their smoking, and they're really messing around with their own health, they can come back with multifocal atrial tachycardia. Maybe asymptomatic, but at least 3 different P-wave morphologies will be seen. Alright, so if you look up multifocal atrial tachycardia on Google, you try to find more ECGs of it, you'll see even better things than this. But basically what you're supposed to notice is very weird looking multi-faceted P waves. So for example, here you can see there's one type of P wave here, right? And then there's a different thing here. This P wave looks very different from whatever happened there. Generally speaking, I only see one bump right there, right? There's that one bump in that one. Here it looks like some kind of weird squiggling is happening, right? So I'm accentuating what I'm seeing right there. Looks like a weird squiggling is happening. And then look at this one right here. And this is a very normal looking one. And so we just found 3 different ones right there. And that's the main thing they're kind of trying to show you here, right? Multifocal atrial tachycardia. 3 or more unique P-wave morphologies and a heart rate of more than 100 beats per minute. Treat just like atrial fibrillation, but avoid beta blockers if the patient has COPD, which is something you should remember from step 1, right? You never want to give beta blockers to a patient with COPD, especially because the beta 2 receptors are in the lungs, and that can be a problem, right? Beta 1 receptors are in the heart, and if you use beta 1 specific beta blockers, that's a different story. That would be okay. So before we move on, let's take a look at some of these questions related to some of the things we just did. First one up here, the left one was the one given in the question, and then they explained it with this. So this is an AMBOSS question telling you, a 40-year-old woman comes to a physician for a 6-month history of recurrent episodes of chest pain, racing pulse, and difficulty breathing. The episodes last up to several minutes. She also reports urinary urgency and 2 episodes of loss of consciousness followed by spontaneous recovery. There is no personal or family history of serious illness. She does not smoke or drink alcohol. Vital signs are within normal limits. Cardiopulmonary exam shows no abnormalities. Holter monitoring is performed. ECG recordings during episodes of tachycardia shows a QRS duration of 100 ms, regular RR interval, and absent P waves. What is the most likely underlying cause of her condition? So now, only 30% of people got this right. It was AV node with slow and fast pathway. A slow and a fast pathway. Another 30% of people chose bursts of electrical activity from automatic foci near the pulmonary veins, which would be, as we just saw, the pulmonary vein thing. And the pulmonary vein stuff was all about atrial fibrillation right here. Okay, and the other groups, 15% chose macro reentrant rhythm in the right atria through cavo-tricuspid isthmus, whatever that's going to be, and 15% chose pre-excitation of the ventricles. Now, it's really important to understand all four of these answer choices so you can kind of see why AV node with slow and fast pathway is correct for this patient and where the other answer choices would be correct. This patient has palpitations, dizziness, chest pain, dyspnea, syncopes, and urinary urgency. These features combined with narrow QRS complexes and no discernible P waves would suggest paroxysmal supraventricular tachycardia, which is almost likely due to Avnrt. The fast and slow electrical conduction pathways create a non-extinguishable circulating electrical impulse or reentrant circuit within the AV node, and that's exactly what happened to her. So we haven't looked at it yet, but that's this stuff: AV nodal reentry tachycardia, Avnrt. And that's what our patient right now is kind of presenting with. And it's because of a reentry circuit in the AV node depolarizing the atrium and the ventricles nearly simultaneously. But your atrium and ventricles are not supposed to contract at the same time, right? They're supposed to contract one after the other, back to back. So that's why, because they're contracting at the same time, your P wave and your QRS complex are on top of each other. And when that happens, you can't see the P wave. So that's why P wave is often buried in the QRS or shortly after. And if I make this image bigger for you guys, then you can kind of see that. Right, so in here, this red arrow, so let's look at it. Black arrow is pointing out a retrograde P wave. Red arrow is a retrograde P wave in lead V3, and the blue lines are retrograde P waves as well, these blue lines. Right, so there's a lot of P waves here that are just not in the correct places. Okay, and that's a sign showing you that the P and QRS complexes are kind of going off together, and that is AV nodal reentry tachycardia. All right, cardioversion will be the only real thing to do for a patient if they're hemodynamically unstable. Vagal maneuvers like a carotid massage or Valsalva, or even ice immersion, which is known as the dive reflex, and you want to make sure you know what that is. All of these things could help, but the most effective would just be to use adenosine. Right? Adenosine would terminate this AV nodal reentry tachycardia, Avnrt, and the patient should be better. But the main thing about this AV nodal reentry tachycardia is that the AV node is depolarizing the atria and the ventricles at the same time, and you don't need that to happen, right? And in the question we just looked at, they told you one thing that was very important, which was the absent P waves. So this patient, where else can you have absent P waves? Well, you could have absent P waves in some of the other stuff we looked at right here, which is AV block, right? But then in AV block, the AV block things were Brady arrhythmia. They were slow heart rate, not fast heart rate. Our patient in this question has a fast heart rate, right? 100, theoretically speaking. So if you have a fast heart rate and you have regular RR intervals, but you just can't see any P waves, that means that the P wave must be hidden behind the QRS complex, but everything is regularly showing up. Right? And as soon as you think of that, you pick AV node with slow and fast pathway. That is your AV nodal reentry tachycardia. Right? It's definitely a tachycardia. Firing of multiple foci in the atrium near the pulmonary veins would lead to atrial fibrillation, which would have an irregular RR interval. Right? And since our patient is not irregular, it cannot be atrial fibrillation. A macro reentrant rhythm would lead to atrial flutter, where you would see a bunch of P waves, and we could not see P waves in our patient, so it's not atrial flutter. And pre-excitation of ventricles via a congenital accessory conduction pathway. The accessory conduction pathway is the one that causes the delta wave in Wolff-Parkinson-White syndrome, and that's not what our question was about either. Right, so those answer choices should not have been ones anyone picked, but for some reason they did, and whatever the reason might be, we want to learn from it and make sure we don't do it. Right? So the correct answer here was just AV node with slow and fast pathway. Oftentimes, this is going to happen on your step 1, it's going to happen on your step 2 CK. You're going to see a question where you're not 100% sure what the correct answer is, but you should be able to figure out what would be correct for every other answer choice. Right? Like we did here. For the wrong answer choices, like we explained in the last 3 sentences, you should be able to figure out what each answer choice is for, and then realize that that answer choice is not correct for your question. And then if something is left, let's say there's only 4 answer choices and you figured out C, D, and B, C, and D are not relevant for your question, even if you don't understand what A is saying, it's most likely possible A is the correct answer. Right? As long as you can rule out the other ones, so use your knowledge to the best of your abilities and figure out what the other things are. Since they described the ECG recording to you so nicely, you needed to use what was given and figure out the correct answer here. So in these images, what are these? The left one is atrial fibrillation with tachycardia, right? And you can kind of catch that. First things you notice, let me grab my pencil again. First thing you notice is that there's a very so the baseline is kind of messed up, okay? Generally speaking, you want to see a good baseline, right? But we don't see it. We do not see a good baseline. Some of them are going up, some of them are moving down. On top of that, the R's are very close to each other, within 2 boxes, right? Sometimes 3, but within 2 boxes, like here again, within 2 boxes. Right? So this is a pretty high heart rate, and this is just showing you atrial fibrillation because you can't really catch all the P waves. Look at how many P waves we see here. 1, 2. Right? And then here there's another weird thing happening with the P waves, a weird thing happening with the P waves. Right? You can't really catch a very clear and concise, nice single P wave, then PR, then QRS, and then you're going to have the T. You need to be able to see that very clearly. If you can't see it very, very clearly, then something's wrong with the atria because the P wave is atrial depolarization. And you can see how the atrial depolarization is really messed up throughout the ECG, everywhere. Right? So that's atrial fibrillation. And of course we saw the irregular RR intervals everywhere, normal axis and absent P waves. So again, we talked about axis in our first video, right? Left axis deviation, right axis deviation. The main thing is if you have left axis deviation, remember for these things you look at 2, 3, and AVR, right? 2, 3, and AVR. So things should be pointing up. The only ones that should be pointing down are V1 and AVR. Okay, so that's not going to happen here. Let me just go back and show you guys in case we forgot, and check myself too. So for axis deviation, 1, 2, and AVF, not 2, 3 AVR. 2, 3, and AVF would be for the right coronary artery ECG stuff. But yeah, 1, 2, and AVF. You're supposed to look at 1, 2, and AVF to check for the deviation stuff, and they should all be pointing up. Okay. The only things that ever point down are AVR and V1 because those are both on the right side. Okay, V1 gets placed on the right side, AVR goes on the right side of the body. So those guys are going to point down, right? And that, here in this ECG, they really only gave you AVL, AVR, you have your 2, AVF, and 3. Not everything. This is not a standard ECG, but this is a nice ECG because it's very long. So you get to see everything that's happening for a longer period of time. And over time, what you're noticing is that the RR intervals are not equal everywhere. Okay, this is not equal to this one. This is not equal to this one. They're all tiny or too long. And then on top of that, you get to notice that the P waves are all messed up everywhere. Right? And that's what you're trying to look at in that kind of ECG. So this is not a standard ECG, the one on the left, but it's a nice way to look at everything over time. The image on the right, this one, you should immediately, it should just stand out to you very clearly that there's some kind of atrial flutter happening. Right? You can see the sawtooth pattern that we looked at earlier. Right? You can see it here as well. Okay, so that's atrial flutter. And they wrote here is with a 4-to-1 AV conduction due to myocardial ischemia, atrial rate of 240, but the ventricular rate is 60. Okay, left axis deviation. How do you see left axis deviation? So remember in left axis deviation, only 1 will be pointing up, and then 2 and AVF will be pointing down, and we kind of see that, right? 1 is pointing up, so that's the plus sign. AVF is pointing down, that's the minus sign. So this is left axis deviation. Left axis deviation occurs when your left heart is working better than the right heart. Right? So whatever happened to this patient must have messed up something on the right heart. Very important to make sure you remember that stuff because the deviation things are going to help you figure out a diagnosis better. Right? If you see left axis deviation and you're trying to figure out there's a bundle branch block, then it's probably a right bundle branch block because that's why the left heart is working better. Right? So 1, 2, and AVF to figure out axis deviation. And then just like we did in the first video, to figure out bundle branch, you have the William and Marrow mnemonics from V1 and V6. You always want to make sure you can see your R wave progression from V1 to V6. R wave should go from being at the bottom to being at the top, and the transition should occur from V3 to V6. Right, that's the transition phase. So that's your normal R wave progression from V1 to V6. There's a bunch of things that you want to make sure you look at all of it in summary together so that you can actually figure out a diagnosis. And every time you look at an ECG, you should, especially if it's in standard form like the one on the right, you should be able to practice making sure your eyes always move the same way every time you look at an ECG. Looking at 1-2 AVF for the axis deviation, looking for the V1 to V6 R wave progression, looking at 2-3 in AVF to see if there's a MI in the right coronary artery, and then from there move on and figure out what else is happening. At the bottom we have an ABOS question again. So this one says, 6 days after undergoing open reduction and internal fixation of a left-sided femur fracture that he sustained in a motor vehicle collision, a 67-year-old man has sudden onset severe pain and paresthesia in his right arm. The operation and the immediate post-operative course were uneventful. Prior to hospitalization, he did not take any medications. He has smoked 1 pack daily for 25 years. Temperature is 99.2, pulse is 105 and regular, respiratory rate is 25, and blood pressure is high. Physical exam shows decreased brachial and radial pulses, and a capillary refill time of 6 seconds. The skin of the right arm is pale and cold, his left leg is casted. Pre-operative lab studies were within the reference range, but now his lab studies show hemoglobin of 13.8, leukocyte count of 8,300, platelet count is 60,000. His partial thromboplastin time, PTT, is 55, which is bad. Prothrombin time is 14, and D dimers are positive. Arterial Doppler ultrasonography shows occlusion of the right brachial artery. What is the most likely explanation of his current symptoms? And this was a very interesting way to ask something that's very obvious, but it didn't really stick out to many people. So only 25% of people got the correct answer, which is adverse effect of medication. 25% of people chose fat embolization, which is definitely something that can occur after big internal fixation and femur fracture, fracture of long bones in the legs. You can have fat embolization. And 20% chose patent foramen ovale, which really I didn't think it made sense for this answer choice. I would respect more the people picking fat embolization. So let's take a look at why adverse effect of medication. And the adverse effect thing should have come to people when they saw the lab studies being given, especially the PTT being 55. The patient was most likely given heparin following his surgical repair of his fracture for prophylaxis against the DVT. That's standard procedure. This is evident from his elevated activated partial thromboplastin time and normal PT. Subcutaneous heparin is the standard of care for DVT prophylaxis in orthopedic surgery. Heparin administration can lead to heparin-induced thrombocytopenia, and that's what this was. This patient has heparin-induced thrombocytopenia, which is why he's presenting the way he's presenting. Okay, and that's all this question was about. They made the question look much more serious and significant, but and not to say HIT is not serious or significant, but it wasn't fat embolization or a PFO. Fat embolization is a serious complication of long bone fractures and would cause acute onset hypoxia, neurological involvement, and a petechial rash on the axilla and chest wall. But it would not cause a rise in PTT. Right? So fat embolization would not explain the PTT increase that we're seeing in our patient, 55 seconds. A PFO can permit left to right shunt, and there is a theoretical risk of conversion to a right to left shunt. In the right to left shunt, a venous thrombus could be ejected into the arterial circulation, migrate to the brachial artery, but that's exceedingly uncommon and irrelevant to this patient's lab finding once again, where the PTT is 55. Neither a PFO nor the fat embolization would explain why his PTT is 55. Okay, and once you see that, once you see the PTT being 55, that's when your heme-onc stuff, more specifically the hematology stuff, should kick in, and you should start thinking of heparin and HIT, or warfarin, and then warfarin-induced bleeding issues that can occur if you don't do the heparin bridge, right? So you want to make sure you always have that in the back of your mind every time you see a question about someone going through surgery. And then, of course, this should be on your mind too. The fat embolization should be on your mind with the patient going through surgery, after a long bone fracture in the leg, because that does happen. Last thing here is this ECG. So to the left is an ECG of a 24-year-old patient with occasional morning dizziness and palpitations over the past year. She is otherwise asymptomatic. In the ECG, you can note sinus rhythm with borderline bradycardia and normal heart axis. Right? There's no axis deviation. R is more than S in 1 and AVF. Both normal and deformed P waves are seen, so the PR intervals are not consistent. The first beat of lead 3 has an aberrant conduction leading to a broad QRS. Let's take a look at, let me point out what they're talking about. So first thing they said, both normal and deformed P waves are seen, so the PR interval are not consistent. And we can kind of see that, right? There's some kind of weird thing happening there. Another, again here, you see, bifid, right? That P wave looks like it's like that, like an M, right, in AVF, and that's not good. You don't want to see that. And then the first beat of lead 3 has an aberrant conduction leading to a broad QRS. So if you look at lead 3, this QRS right here looks weird. Right? It should just go up and down and then go back to normal. Instead, it came down and then it went like this. Right? And that's kind of weird right there. There is no compensatory pause between premature and normal QRS complexes. So this patient has benign atrial premature beats. And this was a trick question because all you have to do is pick that you don't have to do anything for treatment. Reassurance is enough. Asymptomatic patients, because I told you in the question, this patient is asymptomatic, or at least in the explanation, that the patient is asymptomatic. Asymptomatic patients with atrial premature beats do not require treatment and should be advised to avoid triggers that can worsen these things, such as alcohol, caffeine, or stress. And of course, avoiding all three is very difficult. For the most part, especially in America, most people will definitely be having caffeine and having stress every day. And then of course a lot of people look to alcohol to relieve some of their stress, which will all come together and worsen this. So over time, eventually this person might require treatment, especially if they tell you, this is a 24-year-old, but if this person was even busier than a 24-year-old, and 24-year-olds in America are very busy because by the time you graduate college, you search for a job and you start working in the finance industry, you're a very busy person at age 24 already, 25, 26, even more. And if this is a 24-year-old that went to med school, then that's a whole different level of busy in a different manner. So either way, this person will eventually require treatment, but at this moment, nothing. Okay, so get good at noticing ECGs that can look funky but don't really require treatment. Remember that nothing paints a picture alone. The ECG is one thing, then the clinical presentation of the patient is a whole different thing. If the ECG looks a little messed up but the patient has no symptoms whatsoever, chances are you don't need to do any treatment. Okay? And if the ECG is really messed up and the patient has symptoms, then of course you're not just going to send the patient home. You have to do something. Either you're going to put them on a pacemaker if necessary, or you're going to put them on a new medication if necessary, right? But you're not going to send them home because they have symptoms, right? So that's kind of what we're looking at here. So that's good enough for now. In the next video, I'll dive into the more complicated things, starting with Avnrt, Avrt, the high yield Wolff-Parkinson-White syndrome, and then we'll dive into congestive heart failure, which is the next big topic in cardiovascular. Thanks a lot for joining, guys. Take it easy, keep studying hard, and I'll see you guys later on.